Hello everybody, welcome, thanks for being here. My name's Katie.
I'm Livia. I'm Ella.
And today we're going to be talking about the diagnosis and treatment of a 31-year-old woman who came into the Massachusetts General Fertility Clinic after 1.5 years of inability to conceive. So 9 months prior to her visit to the clinic, she had a hysterosalpingogram, which is an x-ray that looks at the fallopian tubes to assess patency and the uterine cavity to look for abnormalities. And her uterine cavity was normal, but as you can see a little bit on this slide right there, there's some spotting, which is evidence that there is nodular thickening of the tunica muscularis of the fallopian tubes. And so that spotting is showing that there's an issue there. And the diagnosis for that was salpingitis isthmica nodosa. And so from this first facility, she was referred to an IVF clinic. So at the IVF clinic, she went through 2 cycles of in vitro fertilization. Each cycle used 2 high-quality embryos taken from the patient, but there was no successful implantation and no viable pregnancy resulted from any of the trials. So that IVF facility then referred her to the fertility clinic at Mass General. So a little bit about the patient's history. There was no significant medical or surgical history, and gynecological history is similarly unremarkable. Reached menarche at age 12, and no real red flags here to alert us that there's something really wrong there. For a little bit more history about her, she has a family history of hypertension, colon cancer, and diabetes. She's been immunized against rubella, varicella, and has the BCG vaccine. And as far as medications go, she only takes a multivitamin, so she's a relatively healthy individual. Socially speaking, the patient's been married for 6 years, works at an office job. She was born in Nepal, and she most recently visited there 4 months ago. She also spent about 3 years of her life living in India, moved back to the US from India about 5 years ago. She exercises regularly, eats a healthy diet, so overall she's what appears to be a pretty healthy patient besides this problem with her infertility. So just to get some baseline stuff, they did all of the standard lab testing and viral screening to make sure there were no issues there, and everything came back normal. She had no history of sexually transmitted diseases either, and her physical examination was normal as well. Nothing that set off any red flags. So to try to figure out why the infertility was happening with nothing from the original workup, they did an infertility workup first on day 3 of the patient's cycle. And so they did a pelvic ultrasound. The follicle count was good, and there was normal ovarian volume, so nothing to suggest that that was the source of her infertility. And all of her hormone levels were within the range that they should be for the follicular phase of the female menstrual cycle. So again, nothing really indicating why she's having this problem with infertility. So then they did a workup on day 6 of her cycle. And on day 6, again, there was not really anything that explained the problem. HCG is something that they use to test for pregnancy, negative for chlamydia and gonorrhea. Her pap smear was completely clean, as were all of her pap smears in the past. And the uterine cavity was looked at again, no issues, no scarring, nothing to suggest that there's an issue still. And so to really try to figure out what's going on, they did an endometrial biopsy. And that is where they started to find that there might be some problems. So there was weakly proliferative endometrium, which is not an issue, but the small, non-necrotizing loose granulomas that they found within the endometrium suggest that there's some underlying cause of this problem, and that is likely what is causing her infertility, whatever is causing these granulomas. So they looked at the granulomas. There was no polarizing material within the granulomas, which essentially is just material that is visible when you shine polarized light at it. So none of that was found in any of the granulomas, and they did histology, and no organisms were found as well. So then they did some additional diagnostic testing to try to figure out what is the underlying cause of these granulomas.
So during the differential diagnosis process, there were several factors that were considered when looking at causes for the patient's inability to conceive. The underlying diagnosis was primary infertility due to tubal occlusion. So the first thing that was looked at were maternal factors. In addition, non-infectious diseases of foreign body reaction and sarcoidosis were looked at, and the infectious diseases that were looked at were viral infections, fungal infections, schistosoma, enterovirus infection, parasites, and tuberculosis. And these possibilities were then eliminated one by one throughout the differential diagnosis process. Some key findings about the patient that were helpful in eliminating some of these possibilities were the patient was born in Nepal and spent 3 years living in India. She received the Bacillus calmette-guerin, or BCG vaccine, as a child, which helps reduce the risk of contracting tuberculosis. And the patient was in good health, had no infections, surgeries, or systemic diseases, and was not immunocompromised. She had normal hypothalamic pituitary ovarian function and a normal appearing uterus and pelvis. So these findings were then used to help begin to eliminate various possibilities. Like I said, the first thing that was looked at were maternal factors, because a common cause of infertility is a problem with the embryo, but because both rounds of IVF were used a high-quality embryo, that was not the cause. In addition, the occluded fallopian tubes were considered to be a problem before the IVF treatments were completed, but after 2 attempts failed, that was also discarded. Then, while the uterus looked healthy, the biopsy that was done on the endometrium uncovered non-caseating granulomas, and that helped identify certain characteristics of the disease. Foreign body reactions are most commonly caused by exposure to talcum powder or an intrauterine device. And talcum powder used to be used in medical gloves, isn't anymore, but it was possibly used in South Asia when the patient was young. However, there was no history of uterine surgery or use of an IUD that would have caused exposure to either talcum powder or an intrauterine device. And there was no polarizing material, as Katie said, found in the granulomas, and that, again, is just material that's visible under polarized light. Sarcoidosis is the most common diagnosis for granulomatous disease, and patients with non-caseating granulomas usually have sarcoidosis. But this disease usually affects individuals of Northern European or African ancestry, and this patient is not in one of those groups. In addition, sarcoidosis presents with lung involvement in 90% of the patients, and this patient did not present with any lung problems. Coccidioidotomycosis is a fungal disease that is endemic in the southwest regions of the U.S. where the patient previously lived, but it usually occurs outside the pelvis and is relatively rare in general. In addition, it usually occurs in immunocompromised patients or postmenopausal women, so this patient did not fit any of those factors. To completely rule out fungal infections, a staining of the endometrial biopsy was performed, and it came up negative. Viral infections CMV, HSV, and HPV frequently affect young sexually active women. CMV, cytomegalovirus, is usually asymptomatic during pregnancy, so this wouldn't have caused any infertility problems. And HSV and HPV tend to be ascending infections with the lower genital tract pathology, but no lesions were noted in the lower uterine area, and the pap smear that we took were normal. In addition, there was no nuclear enlargement, no intranuclear inclusions, and no cytoplasmic inclusions, all of which are usually characteristics that come up with viral infections. Further infectious diseases that were ruled out were schistosoma, because it is not endemic in Nepal, India, or North America. Enterovirus disease infection is usually associated with abnormal uterine bleeding, which this patient did not present with. And parasites are usually seen with ova identified in the granulomas, which did not appear in the endometrial biopsy. Some information on tuberculosis. It is the most likely cause of granulomas found in the endometrium, and it is caused by a bacteria called Mycobacterium tuberculosis. The patient had several factors that contradicted the diagnosis of tuberculosis, including the fact that she was healthy and didn't show any signs that commonly occur with tuberculosis. She was not immunocompromised, and she had received the BCG vaccine as a child, which reduces the risk of contracting tuberculosis. In addition, the granulomas that appear with tuberculosis are usually caseating, whereas this patient presented with non-caseating granulomas. And tuberculosis is quite rare in the United States.
Can you explain what caseating is?
Yes, there's a slide with the pictures. So tuberculosis is endemic in India and Nepal, and 45% of the population of Nepal is infected. So the World Health Organization recommends a childhood immunization of the BCG vaccine in both Nepal and India. BCG is the only vaccine that's available for tuberculosis, but it is only 50% effective. It reduces the risk of progression to active tuberculosis in children by 75%. However, its benefits lessen with time, and after 10 to 15 years, it's rendered ineffective. So we can see this here is a non-caseating granuloma. This is a caseating granuloma, and that's identified by the necrosis that surrounds it, and necrosis are just dead tissue cells. Genital tuberculosis can present in asymptomatic women, as this patient was, and the endometrium is involved in 50 to 70% of these cases. Non-caseating granulomas are common in the earlier pre-ovulatory phase of the menstrual cycle, which is when the endometrial biopsy was taken in this patient. So after going through the differential diagnosis process, tuberculosis was the only possible explanation left unilluminated, and so the official clinical diagnosis for the patient was genital tuberculosis.
So to confirm that our patient did in fact have genital tuberculosis, we took a sample of her menstrual blood and performed an endometrial biopsy. These were both sent for culture, and they were both tuberculosis positive. That's a tuberculosis culture. We also performed a T-spot, which is just kind of a brand name blood test shown there, and a tuberculin skin test. And these both grew drug-susceptible cultures of tuberculosis. So for treatment, we had a combination of anti-tubercular therapy, documentation of culture conversion, and a reassessment of endometrial scarring after treatment. The anti-tubercular therapy we knew we could do because it was a drug-susceptible strain, which was also very important because of the possibility that this patient would go back to in vitro fertilization after treatment was completed, because congenital transmission of tuberculosis can be devastating to newborns. We also counseled the patient in the fact that even after treatment was completed, her likelihood of having a live birth was significantly lower than the general population, especially if there was significant endometrial scarring. So the patient was referred back to the infectious disease clinic for treatment. She was on the standard 4-drug regimen for tuberculosis, which is 4 antibiotics that make up the acronym RIFE, which is rifampin, isoniazid, pyrazinamide, and ethambutol. And these are all antibiotics used in combination to treat tuberculosis. They're usually performed in a kind of a timeline, where the first section, which is the intensive phase, where all 4 drugs are used to really blast the tuberculosis. In this patient, we did stop ethambutol a little bit early once drug susceptibilities were known, but pyrazinamide was discontinued at the traditional 2-month period. At the 3-month period, we took another menstrual blood sample and went for culture, and the culture was tuberculosis negative, which was a great sign. Most pulmonary tuberculosis, I believe, only have a 6-month treatment phase, but this patient went for a total of 12 months. And the continuation phase is just rifampin and isoniazid were used. And the isoniazid dose was increased at the 6-month part because it was subtherapeutic levels earlier on. So after treatment, the patient came back to the in vitro fertilization clinic and had a single embryo transfer of a high-quality blastocyte. She then had 4 other blastocytes cryopreserved. The patient did become pregnant, but suffered from severe vaginal bleeding at the 6-month period and lost that pregnancy. She then returned 10 months later for a cryo-thaw embryo transfer and hormone replacement therapy, which are often used or have been proven that hormone replacement therapy can help with a cryo-thaw and embryo transfer. She did become pregnant, suffered from severe preeclampsia, and was induced at 34 weeks, and she delivered via C-section at a different hospital. So the patient was hospitalized for 10 days after delivery because of her blood pressure, and she birthed a live baby girl weighing 1.9 kilograms, and for reference, the average baby is born between 37 and 40 weeks, and weighs between 2.5 kilograms and 5 kilograms. So this baby was severely underweight. However, as of September 2016, the mother was normotensive and the baby was 4 months old, gaining weight and doing well.